We got a retest. She sent the email out now
Show up
at 9
tomorrow
a.m.
at
this
9.
morning. So you should have it.
Okay, so let's wrap this stuff up so we can work a little bit, maybe on some calculations, it sounds like, right? No, but you guys, sounds like y'all have it on your API form from what Dawn was showing me. Yeah. How much is your API form worth? 15%, so y'all wanna try and do well on that, don't you? That's a big chunk. That could really be the tipping point. Okay, so guys, listen up. This one slide gives you the same concept. No, I gave you that as interesting reading material, and I asked y'all to please hold on to it for your Adult Health 1. It's going to be invaluable for you. Now, I just give it, huh? Well, I don't know. You'll feel better when you go through that simulation and you have this. Okay, so this one slide identifies everything that the lady was talking about ABGs. Actually, this one slide can give you that whole concept in a nutshell about the acidosis and alkalosis. Guys, I'm talking. Okay, I'll wait. Y'all get your talk through. Go on, it's fine. Are we done? Okay. I guess I didn't give you your 1 minute, but I gave you extended minutes. There we go. So this is just what she said. Step 1, look at that pH. Is it acidotic, alkalotic, or normal? Those are the steps. Step 2, look at that PCO2 and the bicarb. And then step 3 for me is it compensated, or what's the degree of compensation? You just look at those 3 values. Everybody's always wanting to look at the PO2, even myself years ago. No, don't look at the PO2. You're looking at the pH, the PCO2, and the bicarb. That's all you need to look at to determine whether it's acidotic, alkalosis, if it's metabolic or respiratory. Compensation. Compensation means that we got ourselves back within that pH range of 7.35, 7.45. If we didn't get within that range, and we see that the bicarb or the PCO2 did not tilt to indicate that it was trying to get back within that range, then it's no compensation. Partial is where it's demonstrating that the pH is beginning to move back within that 7.35 or the 7.45, and you'll see an alteration of one of those. Yes?
And we're basing that off of a sample we took before that, another ABG before that, on the same patient, and then you do another one, and then
Yes. Because in the worst case scenario, you have a patient that's totally, if they arrest, you know those gases are bad, right? You know, if they respiratory or they have such a, well, they arrest, let me say, because I always want to, I'm a medical intensive care nurse, so I always tie it back to pulmonary, but not necessarily, because they could arrest because their acidotic state's totally related to metabolic situation. So could be total condition like that. But yes, and you track these gases. You'll be tracking them. The doctor will order ABGs 30 minutes after a code, for instance, after you've got them intubated. Maybe didn't code. They put them on the ventilator and you reevaluate based on your your settings on your ventilator, and then he'll make adjustments to the ventilator, or i.e. not just adjustments to the ventilator, he'll make adjustments to the IV fluids. Because sometimes you have a situation, you have severe metabolic acidosis, maybe they haven't arrested, but they're a person, they came in with DKA, diabetic ketoacidosis. So those patients are going to be, I will tell you, metabolic acidosis. So you'll see these patients receiving normal saline 1,000 milliliter bag with 2 amps of bicarb and 20 milliequivalents of KCl, and that's running at 150 milliliters an hour a click because they're dehydrated. Their potassium is off, and they're in metabolic acidosis, so what can we give them? We can give them bicarb in their IV. Full compensation is when they get back within the range, that pH range. That's what we want. We want to be in that steady state. Steady state. Here's a nice slide I actually pulled from your book to make it easier for you, because I concur that this is an intense chapter. I'm trying to help you. So I created this slide that gives you those clinical manifestations and the interventions that you'll see for each one of these conditions, so y'all can review those. It's going to be metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Those are the acid-base imbalances that you see. That's what you got to know. Okay, so let's have some fun here. Patient has following ABG, the pH is 7.3. Is that acidosis or acidotic or alkaline? Acidosis. The PCO2 is 40. Is that, what is that? Is it within normal range, right? The bicarb, but it's on the higher end of normal, maybe, right?
Yeah.
The bicarb is 19. Is that low or high? Low. And I threw that distractor in there, that PO2, because people want to look at it, right? It's a distractor. What is this acid-base imbalance? What would y'all think it would be? It's not compensated yet, because why? pH is 7.30, right? It's metabolic acidosis. We can say that it's not even partially compensated. We can say that because why? That PCO2 wasn't higher, right? It was sort of within the normal range, so it really wasn't doing, it wasn't even partially compensating. Y'all see that, right? 7.3, PCO2 40, that's within that normal range. The bicarb was low, hence there's no partial going on here, it's just metabolic acidosis.
So would it be uncompensated then?
We're just called metabolic acidosis. Or you could say, I don't know if there is a term uncompensated. It's just point blank metabolic acidosis. You'll have the condition, or you'll have partially compensated or compensated. That's how it's normally worded. We don't even look at that PO2. That was called a distractor. And in your book, you actually have some practice questions, and y'all break up and look at those on your CD. Yes. So nursing diagnosis, and I will tell you guys, you'll potentially have, because again, I am not selecting the questions. Ms. Agassiz selected from my bank that I submitted. But if you have a question, it'll be that easy for you to figure out. If you have a question about a ABG, you see. It will be that, because just stick to the facts. You're looking at the pH, the bicarb, and the PCO2. That's what you're looking at. That's, you know, it won't be one of these tricky ones. Nursing diagnosis that would be appropriate. Impaired gas exchange is appropriate for a client with a disorder affecting their gas exchange at the alveoli capillary membrane level. Does that make sense? Gas exchange, impaired gas exchange. One of your many nursing diagnosis, 500 plus and counting. You too can submit a nursing diagnosis to be considered. I'm sure they've all been thought up, but who knows? So now we move on to this next section, and I believe this was a section that y'all didn't necessarily have to read in your book. Is that right? Was this the omission, the omitted part, or I'm not sure. But I still felt it's important enough because I know that you're going to have something on ATI. Maybe it's not even going to be the fundamentals. Maybe it's the ATI pharmacology now that I'm learning about things here. But you have reasons for IV fluids, and basically it's to maintain or restore that homeostasis within the body, that fluid balance. Replace those electrolytes. Give those vitamins. You have a patient that comes in and he's a history or she's a history of chronic alcoholic. They come in as John Doe off the street, which that happens frequently. And what they'll say, the doctor will order what they call a banana bag. And it's got vitamins and folic acid, it's got all this in it. It looks yellow, so that's why we call it banana bag. It's a mixture. You can also have IVs for individuals, maybe they're in a state of, maybe got pancreatitis going on or something like that. And in those states, you can't feed the gut. They have to be NPO, and they have the NG tube, same with something lower intermittent wall suction, but they got to still have nutrients. So what they'll give them is what they call total parental nutrition, TPN. And then sometimes you got to give blood because you've had some sort of trauma or you have loss of blood in surgery or whatever, GI bleed, etc. So you have types of solutions. You have crystalloid solutions. Crystalloid, and we sort of talked about it in those first video, talking about the isotonic and hypertonic and hypotonic solutions, right? I can imagine on your pharmacology ATI that they might ask you a question that say which one would you anticipate that would be an isotonic solution? Select all that apply, or consider these, which would you select to be an isotonic? So you have two selections there. You see how that would work? Hypotonic, hypertonic. So this slide would be very useful for you in preparation for your ATI pharmacology test. And I didn't even know that. I have no idea what will be on your test. But I can imagine that this could be a question that talks about these solutions and the isotonic, hypertonic, and hypotonic. Colloid solutions. Those are typically those blood products or blood-based pipes products. Plasma. Fresh frozen plasma. Plasma expanders. The 5% albumins that you have in 250 milliliter albumins. Blood products. This is considered a packed blood cells. And just a little content about what our blood consists of, mostly plasma. And you could have on your ATI fundamentals test, quite frankly, you could have a question that relates to compatibility of blood products. You know, we've had patients that simply they die because we have given them the wrong blood, hemolytic reaction. You guys could simply have a question on your ATI that talks about these blood compatibilities, these blood types. Which one is the universal donor? Which one's the universal recipient? You see, you could have this and how easy that could get mixed up in your mind. You see. But now you have this information for when you sit for the ATI fundamentals, and all of you is going to make level 3. Right? Yeah. Say yes. Check. Yes, check that out. Blood transfusion. Blood transfusions. Before you do anything, you get the order, you confirm the order. What are you going to do next? Make sure you get this consent done. Double check that that patient's not a Jehovah's Witness, because their religious practices don't allow blood product.
So if they do
Had a
blood, they
patient,
just die?
huh?
So if they do,
No, they have other alternate kinds of non-blood products, not quite as good, but they have created these alternate products. But I recall this new graduate nurse, and he was just a really nice guy. Real nice guy. New nurse though, and got an order for blood, and he the patient was, I think at that time, that patient was unresponsive. And the doctors said, go on and give the blood. Give the blood, he's going to die. There was no family around. This new nurse, he went ahead and gave the blood. Yeah, he gave the blood, and then family comes in. They come in on the tail end of that blood administration, they freak. We are Jehovah's Witness. Yes. Well,
so Jehovah's Witness, it's like they have soy blood for vegetarians. You know, like vegetarians eat soy instead of meat. So like Jehovah's Witness have like a knockoff blood.
what now?
So you know how vegetarians don't eat meat. They
Yeah.
they'll have soy and it looks like meat.
It's the blood substitute.
So
Yeah.
it's like a blood substitute.
Oh,
like soy
okay.
is a meat
Yeah, well, we
substitute.
have these products called Hespan and things like that they have now out. But that was a very interesting situation that new nurse had gotten herself into. Yeah, well, we argued the point, well, there was no family and.
Usually they carry a car in their.
Yeah, well, you know, I don't know if they investigated it that thoroughly.
He needs to put a little bracelet on them.
Yeah.
If they don't want that kind of stuff, they will let you know.
I just know it was an interesting experience that day at work.
Normally when you give blood products,
I wasn't his preceptor, thank goodness.
normally when you give blood products, you have to get consent.
Yes, you'll get consent for blood products. Now, a lot of times what happens is when you admit a patient into the hospital, someone has to sign that they agree to the treatments, treatments that still could result in risk of dying, right? They have a broad general form when you go through the admission station down there in the, before you get admitted to the hospital. But on top of this, when they have a patient the doctor has ordered blood, we get an additional consent. And that consent, once it's signed, it's good for the whole hospital stay unless it gets rescinded, the family or the patient decides they want to rescind it. It's good for the stay of the hospital. Sometimes when they have surgery, they can, you have a section there saying, I agree to blood or blood products. There's a separate section on the surgical consent, and that too can serve as consent for blood products through the stay of the hospital. But this would be simply, patient comes in, they're a GI bleeder, doctor decides to administer blood, right? So it's a separate consent, because they're not going to surgery or anything, you're just going to get some blood. Normally, you want to start an 18-gauge angiocath. That's the preference, 18 gauge. Preferably 18, but you got at least a 20 gauge. Because sometimes you have these frail patients, and it's really tough trying to get an IV access. Blood is an important thing that you got to pay special attention. You have to have 2 RNs to do a checkoff on the blood products. You do have to have, if the vital signs are not, they're out of sorts, like say the temperature's elevated, you call the doctor and let him know before you even go get that blood, because maybe you have to do some pre-medication.
Yes.
Once you hang that blood, and you would run that very slowly, because within that first 15 minutes, that's when you're going to see if there's going to be a reaction. It's going to happen within that first 15 minutes, and you basically stay there with the patient, because the reaction's going to occur. It's just going to happen fast. Now, if you pick up the blood, see what I tell my students, I said, now, before you go and pick up blood, you go back in that room and make sure that IV is patent. Because nothing like going, oh, the blood's ready, you go down and get it, and you go into the room and there's the IV's clotted. You know you had the IV, but it's occluded. So what do? You got to start another IV, and you got this blood out. Because you got a 30-minute window from the time you pick up the blood to hang it. And once a unit of blood's hanging, it can't infuse any longer than 4 hours. So be smart, work smart, take vitals right before you go downstairs to get the blood, and also confirm that that IV's patent. Because maybe you got to make the call to the doctor saying, you know, this temperature's elevated before I even start this blood. Yeah.
Was it cherry jasmine? Enchanted.
They can in the ORs, they'll typically use one.
And then to counteract the anticoagulant, what do you
You
give
put the
that?
blood on ice.
The anticoagulant in the blood.
You're talking about the cryoprecipitate, or there's different kinds of blood products that you can give.
So we're given like a whole blood unit and a citrate in it. When do you give the calcium chloride or to counteract the anticoagulant?
Like they're having some sort of blood reaction, they're having a transfusion reaction, or what are you talking about?
In order for a whole blood unit to have some kind of anticoagulant in it right when you collect it. So we're giving a whole blood unit.
You're talking about whole blood, the person receiving whole blood? Well, what, I have never given any kind of upfront medication to counteract, yeah. I mean, maybe there's something that the blood bank puts in the blood in addition, but I've never had to administer anything. But I will tell you, I've only hung, but I will say I've only hung just maybe a few times whole blood units. I'm typically hanging packed red blood cells is what packed. that might be something that the blood bank takes care of, if it's some sort of preservative that they actually add to it to keep that from occurring. But actually, I haven't hung many whole blood packs. Usually packed RBCs, fresh frozen plasma, platelets, cryoprecipitate. Those are the aside from the albumins that are, those are pharmacy created, the glass bottles, the salt pour albumins, but they don't even consider those like blood products. These that we get from the blood bank are the blood products. The albumins that I spoke of, the salt pour, SPA, and the 5% albumins, those come from pharmacy. So transfusion reactions, guys, the one that's most significant, serious, life-threatening, of course all of them are, could be, hemolytic incompatibilities, and that's typically where we have cross-matched incorrectly. We are hanging the wrong blood to the wrong patient. Big problems there, big problems. And what you do whenever you have a blood transfusion reaction, you stop the transfusion. You stop the transfusion and you take down the tubing, the blood and the tubing.
And put it where?
You take down the tubing and the bag totally. You do not spike a saline and infuse through the blood tubing because you're still pushing blood through. Does that make sense? You just take the whole thing. And I was, when you're doing packed blood cells, you're going to have a 250 saline bag, and you're going to have packed cells. It's a Y. It makes it a Y connector. You take all of that down, tubing and all. You take it all down.
You just lay it down?
You take it, you're going to have to send it back to the blood bank because there's a system that you have to do once you've had a reaction. You're going to be having to draw labs. You're going to have to be submitting a urine for urinalysis, filling out lots of paperwork. But this is life-threatening and it can result in patient arresting. So that's why you are very cautious with any kind of blood transfusion, and you stay with that patient. In the NCLEX world, you have no other patient but that patient, do you? That's all the patient you have. You stay with that patient. But in the real world, you stay with that patient that first 15 minutes. That's when it's going to happen. You drip it in slowly. You just don't open that thing and let the floodgates in. You drip in your blood very slowly that first 15 minutes. Because if it's going to happen, it's going to happen immediate. No matter just a small amount of blood being transfused in. It will, if you're going to have a reaction, it's going to happen. This is where we're talking about for Jehovah's Witnesses, some blood substitutes. Hemosol, polyheme, and they probably got many more substitutes out now on the market. That could be on your ATI pharmacology, I don't know. That's a possibility. One doesn't know. What's on this?
Like that guy, what he should have done is given the polyheme and also had no.
Probably would have called, if we knew ahead, if like the guy was aware and we couldn't get a whole family.
So, I mean, if you didn't know, is it better to just assume he is Jehovah's Witness and give
No. It would be the unlikelihood that everybody's Jehovah's Witness, Of course, you might be Jehovah's Witness and I don't know. But I mean, truthfully, there was not really, this guy was an unfortunate situation. He was caught in the throes of this guy was bleeding to death. See, there was no family and he was not awake enough to sign the consent to be able to acknowledge he was Jehovah. See, So we just do, you know, we try to do the best we can. So,
Trying to save their life.
yes, that's what we were trying to do, save their life. And of course, family comes in on the tail end of it. That was an experience. Yeah, it's bad. But they reckoned